Hello, and welcome to today's webinar. My name is Jennifer Roeder. I'm a communications consultant for APFED, and I'll be moderating today's webinar. Today, we will learn about eosinophilic asthma and how to improve care from Dr. Jade Tam-Williams. Dr. Jade Tam-Williams is also known as Dr. Jade to her young patients. She's an associate professor of pediatrics at the University of Missouri, Kansas City, and the University of Kansas Schools of Medicine. She founded and directs the AIR Clinic, AAIR, for severe refractory asthma at Children's Mercy, Kansas City, and is part of the Severe Pediatric Asthma Consortium. Her clinical passions include severe refractory asthma and childhood interstitial lung disease. Welcome, Dr. Tam-Williams.
Thank you, Jen. Let me go ahead and start sharing my slides and share. Thank you so much for the opportunity to speak. Um, so my talk will be on eosinophilic asthma, and I'm really excited to be able to share this information with you. So first off, here are my disclosures. I do some research as well as write content. So our objectives today are the following. My goal is to review different phenotypes of asthma, mainly focusing on eosinophilic asthma, atopic, or what is also known as allergic asthma, as well as eosinophilic non-atopic asthma. We're going to talk a little bit about identifying, avoiding common triggers, or environmental changes, and then I'm going to briefly go over eosinophilic specific treatments that are out there. As you guys all know, there's a lot of acronyms in medicine. And so I may use a number of them through the talk. I'll try my best to actually say the words out loud. But if you are reviewing this later, please feel free to go back to this slide to remember what all the different types of acronyms that are in the presentation. So I'm going to start with two cases. And I like these two cases because not only are they two of some of my favorite patients, but they're really good comparisons on how asthma can present in very different ways. So my first case is actually a 17-year-old young man. He actually presented very severely. An acute onset, had significant respiratory distress. In fact, mom recalled that he had just been at the doctor's office. He had been really good. He had a good, clean bill of health, and then started having coughing, wheezing, and started getting progressively worse. He was so bad, in fact, that he had actually done something called a pneumomediastinum, or what we call popped a pneumomediastinum, which means that his asthma exacerbation was so severe he had actually had a little bit of a leak in his lungs. And if you look at his chest X-ray, you can see two significant things. You can see here there's air in his neck. And that's because the air had leaked out from over his lungs and had gone up towards his neck. But then the second thing also is that he was so severe that he was actually intubated because of this event. On further history, family did say yes, he had some eczema. Yes, he had some shellfish allergies. He really didn't have significant asthma, though. So they were a little bit like surprised by the severity of this presentation. He responded lovely to inhaled steroids as well as oral steroids, and he was able to go home. On follow-up, we actually did what we call a flexible bronchoscopy and a bronchoalveolar lavage, and that's where we take a look with a camera and we take a wash of the sample in his lungs. And in that wash, we put those little sample of fluid that we get back, and we could see that he did have a lot of eosinophils on that. So this is a good example of an eosinophilic asthmatic who has a component of allergies, and then more so even that presented with a very high mortality kind of a picture. Whereas case number two, this is an 8-year-old boy who had a history of reflux, had like poor weight gain, and actually came to me in my pulmonary clinic. And his pediatrician had him on a combination daily inhaler that had a combination of anti-inflammatory steroids as well as a long-acting beta agonist or a long-acting albuterol. And despite that, he was not well controlled. Mom insisted that every time he got sick, it was always a virus. He was not an allergic kid, did not have significant allergy triggers, but he also responded really nicely to steroids. She denied any hospitalizations, denied any ER visits. Everything could be managed at home or with his PCP PCP, but it was just not well controlled. And when I did the laboratory workup for him, he did have higher levels of eosinophils. And when we looked for his allergy testing, he did not have any significant allergies. And he had what we call a normal IgE. And so this is a good example of an eosinophilic non-allergic child who has high morbidity. Their quality of life is very poor, but they're not necessarily seeking tons of emergency room visits or urgent care visits. It's important to note that just because you're eosinophilic atopic, it doesn't necessarily mean that you will be high mortality. You could be easily just high morbidity. Your quality of life isn't that great, but these are just good examples of how things can present differently. So traditionally, for many, many years, we broke out asthma as what we said allergic and non allergic. We didn't think about eosinophilia. We just said, oh, you're an allergic kid or you're not a non allergic. And historically, we would say allergic asthma was mostly kids and about half of adults. And the way you would know this is that you would have skin testing or you would have blood work that would show IgE level antibodies. And then every time you were around something, you would have allergic asthma. There's also the description of the atopic march in children. So, in atopic march in children, typically what happens is there's some sort of sensitization, right? So you're exposed to something, and that exposure then leads to an early presentation of some eczema, and then some cohort of those kids with eczema, estimated some about half. I think some of the studies show about 50% or so get some eczema. And then out of that group, then about some of those get allergies. And then out of that group, some of those end up having asthma. Whereas in non allergic asthma, the description initially was, oh, these are more adults, it's mostly females, they don't typically have a ton of IgE responsiveness, they might be associated with some obesity, rhinosinusitis, or nasal polyps. And historically, they would say, you know what? The non-allergic asthmatics are even harder to treat. Okay. But how much asthma really is due to allergies now? Um, in this table, this one's an older study, but I really like it because it's a nice cohort study looking at a bunch of different populations. And what you can see is they essentially looked at children, they looked at how many of them were allergic, and they looked at how they defined asthma. And what you can see that some these all varied a little bit in how they defined asthma a little bit, but typically they said, if you had allergy testing or one positive skin test ever, um, and the more allergies or more evidence of allergies, then the study found that, yeah, it is more likely that you might have some asthma that's allergic to allergies. But of the cases that were actually allergic to allergies, on average for children, it was about 38%, and on average for adults, it was about 37%. And in some studies, you can even see that like about half of them didn't even have allergies as a contribution. Okay. So, what do I take away from this? So, for me, I take away the fact that, it's asthma is not all just allergic asthma. Okay. So, if you say, you can say, yes, 38% is a good number, but you could also say, what, 62% is of children out there might have asthma that's not allergic related, right? So, what are the difficulties with phenotyping asthma in children? Um, we, as pediatric care providers, recognize that children are not little adults. Um, and there are definitely some issues that are harder for children. And when we say phenotyping, what we're trying to say is like, what is the type of asthma you have, right? And so the first thing to say is that phenotypes or how children present with asthma can change as with time as they change. The other thing to know is that it's hard because some of the ways that we measure lung function in asthma is also changes as they get older. So there's an age dependent patterns in lung function testing. Children also often have what we call more small airways obstruction. Sometimes, if you do spirometry, you'll see this number FEF 25 to 75, or you might hear a doctor say, "Oh, yeah, that's their small airways." Children often may have abnormal small airways numbers, but have relatively normal large airway numbers, or the FEV1. And a lot of our definitions may be around the FEV1. And in fact, even within our pediatric pulmonologists as a group, we have a lot of debate about the FEF 25 to 75 and how useful it is. Children may also be more prone to what we call hyperinflation, meaning that they have more air trapping. They might keep the air in their lungs longer compared to adults. In general, for phenotyping, it's also hard because research in children is hard. Not a lot of parents are open to doing research with their children. And so it makes it a little bit hard for us to know, okay, well, we're looking at adults. Is this completely applicable to this pediatric population? And then finally, one of the difficulties is that there's so many different ways to classify asthma. You could go by age, you could go by the type of symptoms. So, for an example, age would be preschool wheezers. We sometimes you'll hear people say that. By symptoms, you could hear people say exercise-induced asthma versus viral-induced asthma, by how well they respond. Uh, by treatment. So some people might use the word refractory, like this is refractory asthma. By disease course, so saying they're, and this is the most common way to separate out groups, which is persistency. Are they mild persistent asthmatic, moderate persistent asthmatic, severe persistent asthmatic? Are they intermittent asthmatics? And then finally, cellular and genetic. Okay. And we'll dig most into cellular in this particular conversation. There is definitely more genetic work that's being done for asthma, but we're going to talk about cellular phenotyping, and we're going to spend some time doing this in the next couple of slides. So we're going to talk a lot about this, and it might get a little hairy, but I'm going to try to break this down so that we can kind of understand this language that is happening right now when we think about asthma. Okay, so let's start with normal. So in normal, it's important to recognize in normal blood as well as normal bronchial alveolar lavage. um, there are many different types of white blood cells, and we classify the top four are here listed, and those are your neutrophils, your lymphocytes, your monocytes, and your eosinophils. When we look at blood cell types of white blood cell types, the most common type you'll see is neutrophils. And that's important, right? Because what neutrophils do is they're meant to fight bacterial infections. And so you want your blood to have more of those because they need to go to different places and secrete enzymes and fight bacteria and fungi and viruses. Um, and in blood, lymphocytes also are helpful, but historically, we say they're more helpful for viruses, for instance. Monocytes are in the bloodstream because they need to travel to different parts of the body in order to turn into macrophages. And then eosinophils have historically been associated with maybe some autoimmune conditions, but usually allergies and parasites. But if you notice, there's not that many eosinophils when we think about the percentage of white blood cells that we're looking at. It's 0 to 5% compared to neutrophils, which is 40 to 60%. Now, looking at the lung. So a bronchoalveolar lavage, as a reminder, is we take a little camera, we put it inside the lung, we wash the airway a little bit with a little saline, and then we send that little bit of saline fluid sample off to the lab, and we take a look at it under the slide. When you look at a lavage, a normal amount of lavage, that main numbers that you're going to see are really lots and lots of macrophages. So these big fluffy kind of cotton candy blue kind cells. And macrophages are important in the lung because again, macrophages in the lung, its job is to kind of eat up bacteria. It acts on the peripheries. Okay. So uh, but if you look also, not a lot of neutrophils and not a lot of eosinophils. So really, if you see eosinophils in the lung, that's pretty abnormal. Okay. So to give you a sense of what is normal, and so now when we think about airway inflammation, thinking about it from a cellular level, what we have historically started to break it down now, or by is eosinophilic, neutrophilic, mixed, meaning both eosinophils and neutrophils are high, paucigranulocytic, meaning both neutrophils and eosinophils are normal, or allergic. Now, allergic can be with or without eosinophils. Why does this matter? Are we just, spending a lot of time thinking about this kind of stuff and uh, for no clear reason? For me, the main reason to why a doctor should be thinking about this is because it allows you to provide a more personalized approach to asthma care. Um, so I'm going to spend this is a nice diagram to kind of give you a comparison. And we're going to spend some time on this one too. So when you look, I don't know if you can see my pointer or not, but when you look at this first group here, up in that top quadrant of airway smooth muscle right under health, you can see that those airway smooth muscles are very nice and thin. They're not thick. You have what we call a reticular basement membrane in the lung. That's sort of, I call it the scaffolding in which everything sits, okay? That's really nice and smooth too. The epithelium, which is the lining of the lung itself, again, nice and smooth and intact. So in healthy lung, the smooth muscle is nice and thin, the reticular membrane is nice and thin, the epithelium is intact. When we look at asthma, eosinophilic allergic asthma, what you can see here is you get the introduction of allergens inside the lung. And this starts a cascade of inflammation, which we're going to talk some more about, that then leads to these airway smooth muscles being bigger, more what we call hypertrophic. You see this IgE response, these are antibodies for allergies. You see this mast cell releasing histamine, and all this leads to an inflamed airway. So that leads to a reticular basement membrane that's a little bit bigger, more mucus that's secreting out, and your epithelium now becomes broken down. And in a non-allergic eosinophilic inflammation, you get the same kind of irritation, but not necessarily by an allergen. It could be by pollutants, it could be by microbes, it could be other things. And it starts the process out too that brings the eosinophils to the airway through different types of cells. But it's same effect of larger airway smooth muscle, thicker basement membrane, kind of an epithelium that is not as intact, and a lot more inflammation and mucus production. And then on this side, I like just to briefly highlight, these are what we would consider our non-eosinophilic asthmatics, or what sometimes we also say Th2 low or type 2 low. And this is what I talked about before, these neutrophilic asthmatics and these paucigranulocytic asthmatics. I won't get into them today because that's not the purpose of this talk. And then down here, this the diagram artist tried to demonstrate that mixed would essentially be a combination of these two on the bottom. Um, so when we talk about type 2, people say, "Oh, type 2 asthma or eosinophilic asthma." So what defines this? So type 2 asthma is defined by elevated eosinophil and then elevated fractional exhaled nitric oxide, which is an indication of eosinophilic inflammation. Those are the typical cutoffs that docs may use. There's also then type 2 cytokines. So type 2 cytokines are like the messaging service. So we typically talk about IL-4, IL-5, IL-13, and these are produced by different types of type 2 white blood cells or type 2 lymphocytes, and they are part of the activation process on the type 2 side. And then we say type 2 inflammation means, hey, this is inflammation from these type 2 cytokines. The way I like to think about this is I like to think about a cell phone and a message. Okay. So I like to think about my eosinophils sort of as a cell phone. And it is sending off signals for my airway to be inflamed. Okay. And those signals are my cytokines. And that's kind of how I like to think about it. And sometimes cytokines might have multiple overlapping roles. And when we think about the importance of type 2 inflammation, again, to emphasize why it's important to differentiate is that we recognize, and it's been described, that type 2 eosinophilic airway inflammation seems to have less control. Their lung function seems to be a little bit worse. They're a little bit more responsive to albuterol than non-type 2 asthmatics. They are reported to have more exacerbations. The good thing is they do seem to respond really well to steroids, though there is a category of these type 2 asthmatics or that don't seem to respond to high doses of inhaled corticosteroid. Um, there's still some debate on how they present. There's studies that show that they're about half of mild to moderate persistent. Some of them show up really early. If they show up really early, they think these kids seem to be more allergic. Whereas if they show up more like as an adult, maybe they're less allergic. Um, and again, these eosinophils act through and are affected by type 2 cytokines. And there are three right now that we spend a lot of time thinking about, and that's the IL-4, the IL-5, and the IL-13. Each of these do similar but different things. So, for instance, IL-4 is a message that will start the process of turning a T helper lymphocyte that doesn't is could be type 1 or type 2 into type 2s. Um, IL-4 also starts that process of IgE switching. So that creation of IgE immunoglobulins, and it recruits eosinophils to the airway. So it says like, hey, come on over here. I need you to come to this lung because something's happening here. IL-5, on the other hand, it helps mature and activate the eosinophils. It'll also stimulate the bone marrow to create more eosinophils. And wherever they are, it seems to attract eosinophils to them. They will also recruit mast cells with an IL-9 too. IL-13, oftentimes we think of as acting together with IL-4 to make IgE. IL-13 has some interesting stuff on mucus production. So I always talk about my kids who are what I call mucus hypersecretors. They're just these kids that are super wet and junky whenever they have asthma. They don't have that standard typical wet cough. They just have that means standard dry cough. They usually have a really wet cough. They also seem to be involved in airway responsiveness, also recruits eosinophils to the airway, and stimulates the INOS system to lead to a higher level of fractional exhaled nitric oxide. So it's an indication of eosinophilic inflammation. Whereas IgE is a type of immunoglobulin. IgE is an antibody that is produced by B cells under the influence of IL-4 and IL-13. And its job is to go to these mast cells and say, hey, I need you to release a whole bunch of histamine. I need you to start that allergic process. And by that, it then starts this what we call bronchoconstriction or airway narrowing. And it has a role in what we call acute or immediate bronchoconstriction, but it also has a role in this late response. If you have it, it does make it more likely you're going to have allergic asthma if everything else fits, but it's not necessarily a predictor of asthma. Um, and then you may also see it with extra eosinophils. Okay. Um, I think it's as you know, when we were thinking about this talk in particular, and they presented this idea to me, I think in general it's good to understand the difference in triggers. So the first thing is there are allergy triggers and irritant triggers, right? Um, an allergen trigger, by definition, is a substance that causes an overreaction of the immune system that leads to a histamine response. There's an itchy component to it. There's a maybe a swelling component to it if it's anaphylaxis, but that response is specific to the individual. Most commonly, our allergens are pollen, dander, like dogs, cats, dust mites, molds, foods, roaches. And if you have it in your nose, it's allergic rhinitis. Whereas an irritant is a substance that directly irritates the skin, or the mucosa of the respiratory tract by damaging it or by inflaming it. And the difference between irritant and allergen is that really an irritant can affect anyone if intense enough. So, as an example, a little bit of smoke will bother an asthmatic. A wildfire that you are in the middle of and you're having smoke inhalation is going to bother everybody, right? So that's a difference between, you know, an irritant, right? So when we think about smoke, most commonly irritants are like air fresheners, VOCs, candles, smoke, dust, gravel roads. And when you have irritants in the nose, that then we say is non allergic rhinitis. More often than not in the springtime, this is my problem, right? So in real life, and I just had a kid just today who did the same thing. The parents are like, "No, I really think he's super allergic. He's always sneezing. He has horrible runny nose in the springtime." And we do allergy testing, and he is not allergic. Um, but if you think about it, their car looks like this outside their house, right? So I always tell my families, I said, if you can write your name on your car, you don't have to be quote unquote allergic. That pollen is irritating your nose. You don't have to be allergic to the pollen. It's causing rhinitis, it's causing inflammation and drainage because it's so irritating. Okay. So to tie it all back, so when we think about eosinophilic asthma, here here's a picture that sort of puts it all together, which I really like. So in eosinophilic asthma, there is some antigen, something happens. It then presents to these dendritic cells, which then starts the process of these Th0 cells turning to switch into a type 2 cell. So this one here is a type 2 cell. In a type 2 cell, it then makes all these cytokines that then activate that type 2 inflammatory cascade, which then leads to the bone marrow making more eosinophils in the blood. And those eosinophils travel throughout the blood and then go towards the lung and cause problems in the lung. In allergic asthma, you have the same thing. You have an antigen, but in this time, this antigen then causes this switch over to the B cell, creates IgE. That IgE responds to this antigen here over at the mast cell, which then leads to a histamine response, which then leads to airway swelling, mucus production, bronchospasm by the activation of histamine and leukotrienes. So, what are the actual guidelines and what do they say about allergen treatment? There are two major guidelines out in the United States. One is called the EPR4, or the Expert Panel Report 4, which is created by, it's an American based. It only is updated very infrequently, and our last update was in 2020. And what their recommendation was that you shouldn't just do allergen mitigation for everybody unless if they have no trigger. Like if you don't know why their asthma is being triggered, don't, clean out the whole house, but specifically they were thinking about roach. They felt that if you did know what the triggers was, yes, you should do some allergy interventions. And they thought that, yes, you should do pest management. And they said, yes, you should think about dust mites, for instance, impermeable pillows or impermeable covers. But again, they said this can't be a one thing only. You can't just do dust mite pillows. You got to do all the things, okay? Gina said same thing. And yes, the first step is you really should find out, does the kid have allergies? And then yes, you should avoid them if you're sensitized. And they also said, you know what? Just eliminating dust mites when the kid is allergic to dogs, pollens, etc., that doesn't do anything for asthma, which I think is a little bit of a common sense. But so, what's the first step to reducing exposures? The first step is you got to find out what it is. You got to identify what the trigger is. Sometimes parents are able to do this just by observing their child. Hey, every time my kid is around a cat, they break out in hives. Well, you're probably allergic to cat. Okay. The second thing is considering testing. So, either skin prick testing, blood testing, recognizing that each child is going to be a little bit different, right? So um, you might have one child who is super allergic around the dog and another child who's sensitized to the dog, but not necessarily allergic to the dog. So they can live with their dog. Their blood work shows that they might be sensitized, but they're doing fine around their dog. Whereas you might have another child in the same family who every time they're around the dog or around the cat, they have a serious reaction. Most common irritants and allergens can be reduced by improving air quality. So, a lot of things I talk about within my own clinic is I talk about air filters, HEPA filters, changing air filters, improving ventilation. I always talk about reducing irritants such as smoking, combustible smoking, whether it be vape smoke, tobacco smoke. We talk about avoiding wood burning stoves, gas and propane ovens, because again, that's an irritant. And again, remember that for eosinophilic asthma, it doesn't have to be an allergen. It could also just be an irritant that could start the process. One thing that you don't think about is ozone from printers. Usually not your little inkjets, but your big printers can actually be a problem. Cleaning agents can also be a problem, and then decreasing other kind of really strong perfumes. So decreasing irritants is sort of really about improving your air quality in your home. Now, reducing allergen exposures, I like put this all together in this little chart. So, because I do think that the first step is set up a pollen alert. For pollen, it's set up a pollen alert on your phone. It is so helpful. And it really kind of keeps you on your toes. Like, okay, it's time for me to like, if it's medium, that means it's time for me to start taking my Zyrtec and making sure I'm using my Flonase so that when it becomes high, I'm ready. Um, Staying indoors on windy days, which is a little tough, but is in recommendation. Shower and wash your hair afterwards. Nobody really loves this, but the mask was really helpful. That was one of the experiments in COVID that actually was really helpful, which is if you mask up during spring season, you're not going to have as much problem with your allergies. Avoiding mowing, don't hang your laundry outside. Those are kind of other things that, you are catch the pollen on your clothing and then you bring it inside and you wear it. Um, for mold, it's dehumidification, improving your ventilation in the home, getting rid of anything that could be wet or moldy, and recognizing, unfortunately, spores can travel for miles upon miles. From an indoor side, like dust mite, roach, mouse, and pet dander, again, air quality, HEPA filter, dusting and vacuuming at least once a week. For dust mites, that's the bed pillows and the mattresses. And then I always say, don't invest in really fancy sheets because you're going to have to wash those sheets in hot water once a week. And you're going to feel really sad when the Toy Story logo, disappears. For pets, grooming regularly, and then decreasing clutter. And then obviously, if you have a mice or roach allergen, to just get rid of the mice or roaches. There's really no easy way around that other than just pest eradication. For treatment, I always remind my students and my trainees this is eosinophils melt in the presence of steroids. Melt. Like it could be within, 12 hours they're gone. If you put them on a plate, they're dead. So that has been the cornerstone of treatment for decades, which was oral steroids. But the problem is, as we all know, is oral steroids is not a great long-term plan because oral steroids have side effects. And so therefore we moved into this inhaled corticosteroid world. And so your inhaled corticosteroids are typically your mometazones, your budesonides, your fluticasone propionates. And then we even moved more fancy and started doing inhaled corticosteroid combinations. So this is a combination of an anti-inflammatory steroid, so not the kind of steroid that makes you grow big muscles, but an anti-inflammatory steroid mixed with a long-acting albuterol, so a budesonide formoterol or fluticasone salmeterol. And now we're even getting so fancy, we're having a combination of inhaled corticosteroid with a regular albuterol, and you're going to start seeing those come to the market. And then other ways that we've treated asthma that are non-allergic include what we call our muscarinics, our tiotropiums, our ipratropiums, and then our leukotriene antagonists or our pills, which are our montelukast, is the most common ones that you're going to hear about. So, what about the role of allergy treatment in asthma? So, oftentimes allergy treatments are considered add-on therapy for allergic asthmatics. How do they work? Well, number one, they work by decreasing the drip from the nose. So, if your nose is not dripping, then you're not going to get that in your airway and you're not going to cough as much. So, trying to get the nose under control seems to be a component. So, that could be through an intranasal antihistamine spray, such as azolastine, or can through your intranasal steroid sprays like your fluticasone propionates, or oral antihistamines, which most commonly these are cetirizine, fexofenadine, loratadine. And then the other way that these treatments works is just overall by decreasing the level of histamine in the body systemically, hoping to decrease the level of inflammation in the airway. So, what about the role of allergy immunotherapy? So, allergy immunotherapy, you modulate the immune system, in order to decrease responsiveness. There's several different ways to do this. What the guidelines say is that they do feel that for allergic asthma, subcutaneous immunotherapy, i.e., allergy shots, are helpful, but they don't necessarily feel that the sublingual or the immunotherapy, the allergy therapy under the tongue is beneficial. Gina said, either is fine, but really you got to think about, man, that's a lot of time, cost, and potential for anaphylaxis that you need to consider. So really that's a discussion with your provider is kind of what Gina just stated. Beyond inhalers, pills, steroids, and allergy shots, we've now moved into the biologic age. And the nice thing about being a type 2 asthmatic is that there is much more out there in regard to biologic treatments for type 2 asthma than there are for type 2 lows. Um, and those typically include omalizumab, mepolizumab, resilizumab, dupilumab, and benralizumab. I'm going to discuss just real quickly the four omalizumab, mepolizumab, dupilumab, and benralizumab because we do not typically use resilizumab very much in children. Omalizumab has been around the longest. I call it the OG. It's been around for quite a long time, specifically initially for food allergies, and it has been shown to be beneficial for allergic asthma, for chronic hives. You do have to show that you are an allergic kid, and what it does is it actually binds to the IgE itself. So it's based off of how much IgE you have, and it binds to this and it renders it useless. So going back to the analogy of a cell phone and phone signals, the cytokines being signals, then imagine there's a couple ways to stop the signal, right? So you can just block the actual message or block the actual text message out. Whereas mepolizumab does something a little bit different. So mepolizumab and benralizumab, they will actually um, turn off the cell itself. So bepolizumab is an anti-IL-5, and again, it works best for eosinophilic asthmatics, and it's been shown to decrease exacerbations by almost 50%. And the way they work is that they will actually bind to the IL-5 itself so that there's no activation of these eosinophils. Dupilumab is an anti-IL-4 receptor. So again, going back to acting on different types of these cytokines, dupilumab has become very prominent in the marketplace because it's been found to be very effective for a couple of different things, including eczema, eosinophilic esophagitis, as well as asthma. The nice thing about dupilumab, another reason to why I think it's become more popular is it seems to work irrespective of the total number of absolute eosinophils in blood. When I use it, I usually use it in my kids in asthma who have really high fractional exhale nitric oxides. I feel like that's my group that really likes it. But when this drug works, I mean, man, it can be pretty good. But then there are definitely other times where it's really not the drug for that child. Then finally, there's also benralizumab. And benralizumab, I'm going back to the idea of if you say a cell phone with a message, what benralizumab does, it actually binds to the actual receptor on the eosinophil. So when it does that, it actually like causes that eosinophil to self-destruct. So, going back to, okay, if I'm going to try to turn off the message, I can block the signal, I can block reception of the signal, or I could blow up the phone. And that's kind of how I like to think about these biologics. Um, so, finally, in summary, there are many different types of asthma, and now we think about asthma from a cellular inflammatory basis. Allergic inflammation and eosinophilic inflammation often go together, but they don't have to. You might have eosinophilic asthma without allergens. You might have allergic asthma without a ton of eosinophils. The mainstay of treatment in asthma still is inhaled corticosteroids, but I think that the future of steroid sparing treatments will include biologics as well as other types of medications that are not just steroid based. Um, and I hope I have enough time for questions. So, thank you so much for your attention. I'll take any questions if you have them.
Fantastic. Thank you so much for all the wonderful information about eosinophilic asthma to help everyone be able to follow up with their care teams with questions. So speaking of questions, go ahead and open up the Q&A box. You can type in your questions there. And Dr. Tam-Williams and I are going to have a discussion here, kind of talking through those questions. So the first question that's coming in, let's see here. So question about biologics. So do many patients take multiple biologics, or is it something that you take one at a time?
That's a fantastic question. It is very hard to get more than one biologic covered at the same time. There's some research studies that have happened where I've seen that occur, but that is not the common thing. It is typically one at a time. When I do a biologic, and again, every doctor is different, um, I usually tell parents, give us 6 months. And the reason why is because asthma is variable, right? So if you just give it a couple months or 2 months, even, you're not going to see a difference. You might not really know. So you need a couple of season changes to really know if it did anything.
Thank you. So some people, as you mentioned, insurance, those are some other questions that are coming in. Do you have any advice for navigating insurance with
Oh my
biologics?
gosh.
Or
Yes.
even when somebody had been on it and it's no longer willing to cover it?
Yeah, that's tough. So number one, I always recommend everybody, even if you're super wealthy, to sign up for um, for all of the copay programs. Because the copay programs do a couple of different things. They might cover not only the injection, but they may also cover the costs around the injection itself. So, like me going to the doctor's office, the nurse's charge and fee, and those little things add up. So if you're going every 2 weeks, and they're charging you $25 a time, it might be worthwhile to do that. So number one, I always say, before you get on a biologic, always double check what kind of biologics your insurance is going to cover. Number two, sign up for all of your copay programs. Number three, what I am seeing now, practically speaking, is that parents are getting, or patients are going to start getting their biologics declined if they are not filling their medications or their dailies. This is a big discussion within asthma providers, because the point of these shots is to get you to the point where you are not needing the level of medicine that you needed before, right? So that if you're needing a very high dose anti-inflammatory, our goal is to get you down to the lowest dose possible. And sometimes it's so good, those shots are so good, um, you start forgetting you have asthma. So you stop filling your medicines. And so when you stop filling your medicines, the irony of it is that then insurance companies say, well, now you don't have asthma anymore. You don't need these shots. So you're kind of in a catch 22 as a parent or as a patient, because you have to keep filling in order to have them keep paying for your shots. Um, that's honestly the biggest reason to why I have seen denials lately, is that we're getting so good with our asthma management. We're not going to the hospital anymore. We're not going to the emergency room anymore. We're not going to steroids anymore. So we stop filling our meds. So now they say, well, you're cured and you don't have to have shots anymore. And then they deny your shots, and then your asthma gets out of control again. So fill your
Thank you.
meds. That's the key.
Th- Thank you for the tip. Alrighty, so pivoting a little bit about a different treatment, can you talk to us a little about low dose naltrexone and its use for eosinophilic asthma?
I cannot. Unfortunately, I do not know
That's
anything
okay.
about that. I apologize.
That's okay. Thank you very much. Alrighty, so we have an individual who has a loved one who has eosinophilic fasciitis in their legs, and they're curious if there's any connection and similarities with eosinophilic asthma.
Um, so I'm presuming that they must have somehow taken like a slide or a sample in order to decide that. Um, so it probably does not, in the sense that the presentation's probably very two different things. But I do wonder if there's some sort of some other inflammatory process. So um, it would be just hearing that, and again, don't not knowing much about it. I would wonder if there's another immune component of some kind, because that's not very common thing. Like if you're saying fasciitis, right, in leg, right? So that's not very common. So I wouldn't say that it would present the same way as asthma, and it might not have the same mechanisms, but it would be interesting to know if there's some other autoimmune component there for that individual. I would probably say, in that case, if it was my loved one, I would make sure they see a rheumatologist.
So
I don't know
what
if I can
a
give that advice or not. I'm sorry if I did, if I wasn't supposed to, Jen. Sorry.
No,
It's-
we appreciate any information you can give to guide people.
okay.
So pivoting back a little bit to asthma here, what are some symptoms, just to kind of recap for people, that people should look for to indicate my asthma is worsening? I should ask more questions and help identify what
Yeah.
subtype it is.
Yeah, yeah, yeah. So the first couple of things there, what I call the rule of twos. Um, so when healthy, again, that's important. When healthy, I'm not sick. Okay. I have cough, daytime cough, wheezing, or shortness of breath more than twice a week when healthy. I wake up at night coughing, wheezing, or short of breath more than twice in a month at night. I'm pulling out my albuterol more than 2 times a week for rescue, not because I'm going to go exercise and I just want to make sure I'm doing my best. Um, or I've needed more than one course of steroid a year. Those are indications that your asthma is not well controlled. If your asthma is not well controlled on whatever the regimen that your doctor put you on, and you have to ask yourself sincerely, are you doing what your doctor told you to do? And then if that's the case, then I would say, yes, it's time to have a conversation with your doctor about whether or not your asthma is well controlled. Oftentimes, we do not talk about phenotyping until you get to the level of a subspecialist, because the first line of care is always an anti-inflammatory steroid of some kind. So that's why most pediatricians are not, or PCPs are not going to necessarily talk about phenotyping. But when you get to higher levels of care, we will start talking about phenotyping and picking the right medicine for you, and what works and what doesn't work. Does that kind of help?
I think it
Okay.
does. Thank
Okay.
you. So once you've been diagnosed with eosinophilic asthma, how often should your eosinophil levels be checked? We hear a lot about
Really
endoscopies with
good.
EOE and
That's a
other
good
conditions like
question.
that.
So
Yeah.
here's the thing. We don't typically do that with asthma. So we will check a pheno because a pheno may go up or down. And some people will always have high phenos, but coming like if their standard baseline is like 200, them coming down to like 120 is like a big deal, right? So we will check phenos to let, because they go up and down, and you will look for a trend, and that's really where a is really good. But for eosinophils, oftentimes we don't necessarily recheck, and in some cases, for instance, you may even see kind of a quote rebound in the blood work that doesn't have any clinical outward manifestation. So that is a really good question. Um, so we don't typically say, oh, every 6 months you have to recheck again. Not like not like EOE.
You talked about a number of different triggers that can impact asthma. Um, can you rehash for us the specific triggers that impact eosinophilic asthma more than other conditions?
Yeah. So for eosinophilic asthma, usually we talk about air quality triggers. So it's still this, it's pollutants, microbes. Um, so I think this maybe, and this is where I wasn't maybe so clear. So for allergic asthma, there is a thing, there is an air, what we call an aeroallergen, right? Some subparticle that you inhale in the air that gets into you that starts this allergic cascade. For eosinophilic asthma, it's really more about whatever that trigger is causes the inflammation, and you yourself create more eosinophils. That's how you manifest your inflammation. Maybe that's a better way of explaining it. So that trigger could still be viruses, it could be irritants, it could be air quality problems, it could still be smoke, it could be um, uh, microbes of some kind. I, and maybe that, if I hope that clarifies it a little bit.
It does. Thank you very much. Let's see. So another question would be, you talked about how helpful biologics can be.
Yeah.
What point in the treatment journey should a patient consider biologics?
These are really good questions, Jen. I'm really excited. I mean, seriously, they're really good. Okay, so um, every doctor is different. I'm going to start that off. Caveat number one. So for children in particular, I will say that the time to think about it is you're using way too much steroid. You're on too much steroid, you're on your highest level of inhaled corticosteroid, and you're still not well controlled. Okay. And that's typically when I say for sure, not a discussion that we got to talk about this. Now, some parents do not want to do shots for their children. That is not the life they want. And so so you may find that for some parents, you just keep doing more steroid. And before we had biologics, what did we do? We just did 5 cc's of prednisolone every single day, and you were good, for the rest of your life. The problem is if you're doing 5 cc's of prednisolone from the age of 5 to 45, that's 40 years, 365 days, right? And I had a parent one time ask me, "Why can't I do that?" And I go, "Sure, you could, but she's only 8." um, what are we going to do with her bones when she's 42? Um, so, so yes, you can always not do a biologic. Number one. Number two is I say for sure if you're on high doses of inhaled corticosteroids, still not well controlled, getting lots of oral corticosteroids, still not well controlled, we got to talk about it. Then the third category is that category of families that say, I'm trying to keep myself from getting to that point, right? I don't want to get to the point of having high dose anti-inflammatories and I'm on an Adver 230. I want to stay here in this medium dose. And I want to talk about avoiding as many oral steroids as I can. And so I sometimes have family elect, to move to biologics sooner than other families do because they say, if I can do this and even minimize my everyday regimen, I would rather do that. I would rather get a shot every 2 weeks, every 4 weeks, every 8 weeks than every single day exposing my child to something that that maybe I could minimize, right? So, but again, great
Yeah.
question. Very individual though, is the short answer.
Absolutely. Well, and that's our hope is that the
Yeah,
information from your presentation and our discussion
right.
arms everyone who's joining us to go have good conversations with your care teams.
Right,
So,
right.
yeah. Is there anything else you would like to share today about eosinophilic asthma?
No, this was great. I really enjoyed it. Thank you.
Wonderful. Well, thank you so much for all the information that you shared today. We really appreciate it. Thank
Okay.
you also to our education partners for their support for this webinar series, including AstraZeneca, Bristol Myers Squibb, GSK, Sanofi, Regeneron, and Takeda. Our next webinar is going to be about anti-eosinophil therapies. We're going to take a look back and take a look forward. So where are we now and where are we going? This is going to feature Dr. Kalman Prusen. And so we hope you can join us on May 21st. You can visit apfed.org/webinar to register. We are also preparing to release the next episode of our podcast. You're getting quick advance notice because it's releasing tomorrow. So our next episode is going to be about comparing pediatric and adult EOE. So we hope you'll tune in to listen to a great conversation with Dr. Melanie Ruffner from CHOP. So our podcast is a great opportunity, in addition to our webinar series, to continue learning about eosinophil-associated diseases. You can subscribe to the podcast through Spotify, Apple Podcast, Audible, and more. You can also check out you can also check out the episode at apfed.org/podcast. We also currently have registration open for our annual conference, EOS Connection. So this year, for our 23rd annual Patient Education Conference on eosinophil-associated diseases, we'll be in Raleigh-Durham, North Carolina from June 26th through 28th. You can register at apfed.org/conference. And if you can't join us in person, this continues to be a hybrid conference, so you can register to join us virtually. Finally, we encourage you to continue the discussion started today in our online community on the Inspire Network. It's a great place to connect with patients and caregivers for support. You can check it out at apfed.org/connections. So thank you again for joining us today for APFED's EOS Support webinar series. If you have a question that didn't get answered today, please email mail@apfed.org. Thank you again, Dr. Tam-Williams.
You.
Hope everyone has a great afternoon.